Welcome to the Framework in Focus, a videocast series where we provide insight into our ebook titled Musculoskeletal Clinical Translation Framework from Knowing to Doing.
That's a mouthful, Darren.
It is. So hereunto, therefore, I will
forthwith.
Yes, refer to it as the framework, I think is a better way to go. We hope this series will complement the ebook and provide additional insight into the whys, whens, wheres and hows of the framework, and this goal aligns with our ongoing efforts to facilitate knowledge translation into the management of musculoskeletal pain. Part 4, diagnosis.
So you're Darren, as I said, I'm Tim, and Helen will be touching base with us shortly, and Peter O'Sullivan also with the next few upcoming sessions around this.
Yeah. This is our warning slide. So we're speaking about individual elements of the framework today, but it must be understood that this is artificial and every element is potentially related to everything else.
Yeah.
So here's our quote for the day. It's a long one, so see how I go with this one. It is important for those living with chronic pain to establish good communication with both their healthcare professionals and caregivers. Clear communication about pain is vital to receiving proper diagnosis and effective treatment. From Naomi Judd. Yeah. It's a very nice quote.
Yeah, it is, and obviously diagnosis is what we're focusing on today, and the communication both for the information to understand it, but as healthcare professionals, us communicating that diagnosis to a person and other family members or significant others is it's huge. It's really important.
Yeah, and a great insight from presumably a consumer in this case.
Yeah.
All right. So this is elements of the framework. We are across diagnosis, specific diagnosis, non-specific diagnosis, and red flags. So and the diagnostic triage kind of concept fits here.
Yeah.
If we start with red flags.
Yeah. So this isn't new. This is accepted across healthcare, not just musculoskeletal pain. But if someone attends a hospital emergency clinic or a GP primary care practice, for example, that's the approach, the diagnostic triage. Are there any red flag disorders, so of significant concern? If not, is there a specific diagnosis that could be applied to that person's presentation? If not, is it therefore then a non-specific diagnosis? But the red flag disorders are obviously ones that need for urgent medical input or assistance.
Yeah. And
we won't go into it here, but there are references within the framework ebook already around the list of those red flags, so individual red flags that might alert you to the possible presence of a red flag disorder, and they're well published across different sort of body regions and different health conditions. Yeah.
Yeah. We do have a reference here, hot off the press paper. It's a framework for looking at red flags, and I guess there are those specific questions, but the accuracy and I guess the specificity and sensitivity of some of those questions as individual questions is not that great. So you need to look at broadly the whole person perspective to understand.
Yeah, so it's a cluster of those questions, or when a cluster of flags put together increases your index of suspicion. And a classic one is, I remember in undergraduate training we used to talk about, I guess, risk of something like the presence of cancer, where you talk about things like night pain or sudden unexplained weight loss or general malaise, for example. But then you'd be asking a patient a question in clinic and they'd say they'd have pain at night, and you'd immediately go, oh no.
Yeah. Yeah.
But there's many specific and non-specific musculoskeletal pain disorders where night pain is a feature of that, and that's nothing to do with cancer. So a single flag by itself is often irrelevant.
Yeah.
Yeah.
And what I really like about this figure is that it kind of portrays that this is not a one-off screening that you do, your first appointment and then forget about it. And particularly, I like the response to treatment there. When people aren't responding, often that can allude more to something more sinister going on than, not always obviously, but at times when they're just not responding, how you think they should,
Yeah.
to a musculoskeletal problem,
Yes.
that can be telling.
Yeah. And look, there's different vascular presentations. I can think, immediately of cervical arterial issues where early onset of those symptoms does often present as musculoskeletal type pain.
Yeah.
But in that graphic there, the level of concern is very important. So if the presentation fits as a mechanical musculoskeletal problem, then we don't have to automatically assume the worst if there's only one or two flags there. But if they're not responding as a typical musculoskeletal pain problem should, then perhaps that index of concern does go up and on referral becomes relevant.
Yeah.
Because there's a difficulty here, isn't there? And it's happened in medicine before where, and I know in the United States is a classic example where referrals to either emergency departments or for further medical investigations, the costs of that become prohibitive because of the concern of we'd better refer everything on and get it checked. But the number of red flag disorders that present in primary health care is known to be less than 1% of people coming in. So they're there and we need to understand that, but we also need to have the knowledge and skills to go, hang on, my level of concern here is high and on refer, or no, it's not. But we will monitor and check back in.
Yeah.
Yeah.
Okay, good. We'll flip back to here. So the specific diagnosis, and this would be the hallmark of the biomedical approach, and that's still part of the biopsychosocial approach, I guess, if we want to try here.
Yeah. And I think we've come across this a lot where with increasing awareness of the biopsychosocial model, there's this tendency to go, well, let's not worry about pathology. And there's a balance there where at times the specific diagnosis and specific pathology is highly relevant, and that's the main driver of a disorder. So we still need to have the skills to identify that and direct management accordingly.
Yeah.
But balancing that out with the greater proportion, and we know 90+% of musculoskeletal presentations will fit into that non-specific category. So I guess there's a foot in both camps, if you like, around that. What are your thoughts on that?
I'm thinking of the issue with scans that's well documented around chance findings that aren't related to the person's pain necessarily, but then the real difficulties as a clinician in terms of trying to understand, is the change on the scan relevant or not? It might be relevant from a beliefs perspective also. We'll talk about beliefs later on, but just that basic level, is the pathology relevant or not? So if you have a fractured femur, then it's probably relevant, but if you have motor changes in a disc, is that relevant?
And it's not a simple answer for this, and people like things to be simplified, and we've talked about quotes earlier on of trying to oversimplify things. We've seen this because we do a larger proportion of our work with more complex, longer term presentations, and it's very easy to slip into that concept. If anything's more than 3 or 6 months, then it's likely to be chronic pain, and we're not worried about specific diagnoses or disorders. But I mean, it's not often, but there's many examples I can think of where I've reviewed a person 6, 12, 18 plus months into the onset of their symptoms, and there's findings on scans that are relevant, or there's other misdiagnoses because of assumptions earlier being made. And I know when we teach around this, but also how we practice with this, is you must still be skilled at asking the right questions and then delivering a thorough clinical examination, and then putting the reasoning of that together. And for example, a common one might be, for example, lumbar radiculopathy. And the second one of that, so someone's got back and referred leg symptoms. So as soon as someone presents with that, whether it's 1 day or 2 years down the track, The questions in my mind are excluding common specific pathology such as lumbar radiculopathy, or is there referred leg symptoms from peripheral nerve sensitivity, which is still quite a localised specific issue, versus more somatic referral or just broader non-specific back and leg symptoms.
Yep.
So from that, there's a structured physical examination process that becomes educative with the patient as well. And you mentioned about their perspective or their thinking what's wrong.
Yeah.
So you've got a scan, it's got a disc bulge on there, you've got back and leg pain, let's have a look at that.
Yeah.
So we know there's a cluster of physical examination tests that with pretty good accuracy rule in or out lumbar radiculopathy.
Yep.
So let's conduct these tests and say to the patient, I'm doing these tests now to screen if there's a pinched nerve problem, and talking through those, right? These are actually all normal. Your sensation in that area is normal. Your muscle power that nerve serves in your foot and your ankle is normal. Your reflexes are the same both sides. So clinically, there's not a strong signs here of lumbar radiculopathy, rather than just going straight to, oh look, I know you've got that on the scan, but lots of people without pain have that on their scan.
Yeah.
You cannot discount it until you've considered it and assessed it.
Yeah, and I think patients really appreciate if you've done a hands-on thorough assessment in some way, they're much more willing to take that message.
Yeah, and it might be another example is the person may only have back pain and they say, I think I've got a pinched nerve because that shows on my scan. And we know, well, hang on, if you haven't got leg symptoms, we're not worried about that. But it's not us we need to reassure.
Yeah.
It's the person with the problem.
Yeah.
So we can say, fine, I hear you're concerned about the pinched nerve. Let's do those tests to double check.
Yeah.
And how long does it take you to do that testing process?
A couple of minutes, probably.
Yeah. So within 2 minutes, you can assess and reassure that person.
Yeah.
And that may be the most important part of that consult.
Yeah.
And the other side is, at times when there's back and leg symptoms that are a long way down the track, sometimes you do go, well, hang on, there's loss of power, loss of reflex specific to a, say for example, in an S1 distribution, and there are signs on the radiology of nerve compression. There might be a specific diagnosis here that's been missed.
Yeah.
So
Yes.
it is bloody important, and then the counter to that is if we do that examination early in the acute phase, we can quickly rule these things in and out, give the right information, and move forwards from there.
Yeah, good. So probably just to reiterate and paraphrase that the hands-on approach to match that with pathology is critical in terms of seeing if there's a specific diagnosis. And maybe just the other quick thing is to say, as a clinician, don't ignore that, particularly when communicating with other health professionals.
Yeah. And there's other specific diagnoses. I can think of rheumatoid arthritis as another example that as physiotherapists we may not think of so often if you're zoning into the symptom presentation, but again that's a specific diagnosis that has specific medical management that can make a significant impact on, I guess, altering in a positive way the course of that condition.
Yeah.
So we don't want to be missing those things early on.
No.
So even if we're not primary contact practitioners, it's still incumbent on us to have some awareness around that, to be considering those different diagnoses.
Yeah, very important.
So they're not so common, but they're common enough that we need to be aware of them.
Yeah.
Yeah.
Good. Non-specific diagnosis. So you did mention earlier, maybe we're looking at as many as 90% of people with pain. It's non-specific in nature.
There's certainly the numbers around that that we see in different studies on conditions like back pain or shoulder pain, for example. Now, there's a couple of things here that's important. One is, what is a specific diagnosis versus non-specific, and this has shifted in our thinking. So generally a specific diagnosis is associated with clearly identifiable pathology, and then also a clear course of management around that. So for example, rheumatoid arthritis, there's blood tests and potentially radiology that can assist with that, and then there's specific medications that are disease modifying medications around that. So rheumatoid arthritis is a specific diagnosis around that. There's other diagnoses, such as if you think about the shoulder, previously people have said you've got a partial tear in your supraspinatus tendon, whereas that says there's a tear in your tendon, but the correlation between that identified structural pathology and pain we now know is not strong.
Yeah.
And that more broadly fits under a diagnosis of subacromial pain,
yeah,
which is the accepted diagnosis for subacromial bursitis and perhaps tendinopathy as well, and other disorders of subacromial structures. While that tells us where the problem is, it's still relatively non-specific because it doesn't tell us what we need to do about it.
Yeah, umbrella term.
Yeah. So I think people find that challenging around, well, is this specific or non-specific? I think there needs to be less concern around that. So you can put a diagnostic label on something, like you've got subacromial pain or you've got patellofemoral pain, but that doesn't then tell you what you need to do.
Yeah.
And that's where I think the framework is particularly helpful for going, with your patellofemoral pain, these seem to be the factors, which may be just physical overload because you're doing too much versus muscle flexibility or strength, for example, or other factors that might be driving that.
Yeah. Good point. Anything else on the specific diagnosis you want to mention, or should we?
Well, one more thing that comes up is you might have a specific diagnosis, which is, say, lumbar radiculopathy.
Yeah.
But again, then there's not a very clear course of management that everybody needs. So not everyone, as you know, with radiculopathy needs surgery.
Yeah.
And there can be different approaches for different people and different of the individual elements of the framework that might be dominant. So an example could be someone with lumbar radiculopathy that's very compressive, that's not resolving, and perhaps there's progressively worsening neurology. They're a case that surgery might be relevant. Other people with some neurological signs but that's stable and slowly improving can equally do well without surgery. And then within that, some people will respond to different medications, some people need to be reassured, some people need to modify their activity levels, some people need to get better sleep to help their system recover. So that's the interesting bit. You might still have that label, but the individual management is where
it's different. So tricky.
Yep.
So, all right, I think we'll move on to these other questions we kind of had.
Yeah.
And it's around delivering the message, because the person does want to know what's going wrong.
Yeah.
And they want that label. So that's in some ways an important part.
Yeah.
But as you said, it might not necessarily always guide management, but it's still important for the person. So, that's what I'm thinking in terms of this first question. What does the person with musculoskeletal pain want? So I think they want a label. What do you think?
Yeah, look, I mean, I think it's human nature to put a name or a label on something, and then that gives people a grounding of where to work from. And I think we both discussed this over time, where we were comfortable with this concept of non-specific diagnoses. But have you got any insights of experiences where you previously have said to people, you've got non-specific back pain, for example?
Yeah. Well, I'm just one that comes to memory is where I did my best to tell this person that they had non-specific pain and what that meant, and very clearly told them that that doesn't mean it's in their head that they've got this pain thing going on. But then later on, through communications with the physiotherapist they went back to, they went away with the message that they thought it was, I told them it was in their head.
And that's a common experience, isn't it?
Yeah.
And I've watched many physiotherapy students I've been involved in teaching trying to relay that message about non-specific pain, and there's been many an awkward conversation or clearly not effective in the intent of that.
Yeah.
So I think one way to consider this is, I mean, that's, as we've already said, it's a internationally accepted diagnostic triage, and it's extremely useful to go, if you have a non-specific pain problem, it means there's no concerning pathology. That's why it's helpful.
Absolutely.
So to say to the patient, we've ruled out red flag disorders, we've ruled out specific diagnoses such as rheumatoid arthritis that require targeted management.
Yeah.
You have, and you don't have to say the term non-specific pain. As clinicians, for us to acknowledge that and go, right, this is in this non-specific category, it's extremely helpful because that'll be 90% of what we see to tell us, right, we're not focusing on just the pathology, we're focusing on the different factors that'll be relevant for that person.
Yeah. There's a lot of focus on the words that we use, and I actually don't believe the words are the problem. I believe it's the explanation of the words, and I think there's more work to be done on that. But even with the best intents, as I said, the person might not take that message straight away, and it needs repeated, consistent messaging around that.
Yeah. But the challenge, as you've mentioned, what the patient wants is a label.
Yeah.
And one example is people have suggested if you ask your patient at the end of the consult, what do you understand is wrong, or what have you taken out of that? That can be really helpful learning for you to reflect back on what they're saying. Or when you go home, what are you going to tell a family member is wrong?
Yes.
Because if they leave saying, well, they don't really know what's wrong, they've just called it non-specific pain, probably not so successful.
Maybe not.
But that's why it's tantalising to give them a label, or you've got a disc problem, or you've got a facet joint problem, or you've got knee arthritis or whatever, because people like that.
Yeah.
But then where they go with that is the challenge. Yeah.
So that does lead into, like, you know, how do you do this with the patient to make sure that they do understand it?
Yeah. One piece of advice I've been given, and I think is very helpful, is when we, in the previous video where we talked about asking the patient what do they think is wrong, that's probably your starting point. Because if they come in and say, I've got back and leg pain and I think I've got a pinched nerve and I might need surgery, you have to label you have to frame your assessment and your diagnosis with that in mind.
Yeah.
As opposed to, I've got back and leg pain, I don't really know what's wrong and what do you think I need? That's quite easy because they're probably quite open to whatever you're going to frame that on. So how you do it depends, and it depends on that person's story and their understanding of their problem as a starting point.
Yeah, so you have to personalise it.
Yeah. Can you think of any examples of how you've done that? Let's say, if we stick with the back leg pain example, let's say you've got a patient with back leg pain that thinks they've got a pinched nerve.
Yeah. And
clinically they don't. How do you deal with that?
Yeah, it's iterative.
Yeah.
So, you know, arcing back on what we were saying before, I'll do peripheral nerve sensitivity tests or pain provocation tests.
Yeah.
If they're clear, then I'll stop and I'll say, well, look, I've just done these tests for your nerve, they're okay.
Yeah.
So I'm not actually worried that your nerve's irritated down there. So it's iterative.
Yeah.
Like
So you're starting your education during the assessment.
Correct. Yeah, an explanation.
Yeah.
But it does make, you know, it is tricky, like when you have a framework like this, you know, there's 8 elements in it, and that's a lot of information for an individual to take away.
Yeah.
So I guess that's something that needs to be balanced in the explanation around how much they can take on.
Yeah.
Mm-hmm.
So the other things that I know you do and I do the same, we write down what's wrong. And my current approach is I'll write as my first label the problem.
Yeah.
And then after that, I oversimplify it intentionally.
Yeah.
So whatever their problem is, I might say in the first line, so you've got back and leg pain. That might be what I write. Or you've got knee pain. Or you've got shoulder pain. And they're going, yeah, that's obvious.
Yeah.
But you're acknowledging that's what they're saying. And then I might say there is a specific issue, so that's related to if there is some clear pathology relevant to that. Or I might write something like, you're sore but you're not stuffed, or depends on their language obviously, or there's no major damage in there, so I'll write that to reinforce it. So I might say where the pain's coming from, like it is coming from structures in your back, or in your shoulder or your knee, or the tendon seems like that's the issue. And then my second grouping, which we kind of have in the framework here, is the factors.
Yeah.
So I'll list the factors, and I might say pathology's relevant, or we're not concerned about that.
Yeah.
And then depending on the order, which we'll talk about in subsequent videos, so that's all laid out.
Yeah.
So it's your problem, the factors, and then your plan.
Yeah.
Of this is what we're going to start to manage it.
Yeah. Yeah, and I think having it written down and is quite critical. As I said, there's a lot to take in. You don't know what they're going to take from that, but if you write it down, at least that's reasonably solid.
Yeah. And then that's the last bit we've sort of talked about. How do you make sure it's understood?
Yeah.
Do you have
Well, no, I think what you
strategies?
said, right, you ask those questions. We'll often, when I'm speaking to other physiotherapists and I've reviewed their patient, I'll tell them to start off the next conversation with them around what they've taken out of that, because it is an ongoing educative process.
Yeah, I think we're fortunate because we work as specialist physios and we often do shared care with other health practitioners, so we're then referring them back and we have some ongoing communication. We've been able to learn a lot out of that.
Yeah.
And like you just said, getting someone else to reinforce the same message is extremely powerful, but we've also had opportunity to get feedback from that, so staff in our own clinic or other health practitioners, where we've done a report and circulated that, and then we've asked that health practitioner to question the person to say, oh, how did you go with that session, or what did you get out of it? So we've had lots of feedback around that, and at times we think we've done a magnificent job.
Yes.
And the person's reflected something completely different. So we're not going to nail it every time, but also it does often take time for people to take this information on board, particularly if it's not aligning with what they've previously been told or their original thinking. So repeat messaging, as you said, and different people giving the same messaging is often important.
Yeah. Two things I thought of. One is around that messaging. Sometimes practitioners are giving the same message, but it's different words, and that can sound like mixed messages. So I might say, oh, you've got neuropathic pain. You might say you've got pain sensitivity. Someone else might say you've got central sensitization. Three completely different things to the the person that doesn't realise they're probably kind of similar. Technicalities aside. So sometimes helping the patient navigate that can be a good idea. The other thing that just popped to mind is, maybe I'll just mention my social experiment of writing all my reports to the person rather than to the doctor or a referrer, to really try and make them have some responsibility around their condition.
So you're actually directing that letter back to the patient, and you're talking to them, although it's going back to the referring medical practitioner. So it seems to go okay, but I don't have an official analysis of its success. But some people definitely have been thankful that their report's written to them, because it is about them in the end. It's not about us or the doctor. It's about the person.
It is. All right, very good. We'll. This is our website, Musculoskeletal Framework.net. Should have just called it the Framework.net.
Should have. No. Things have iterated and changed over time.
You can't change
as with our knowledge.
There's a picture here of our jigsaw puzzle again. In what language is this in, Tim?
Well, I won't show off my language translation. I do know a little Japanese, but a little bit limited, I would suggest. But that's the fortunate part about the framework. We've had different collaborators from different countries that have been doing some of these translations for us, and it seems the base concepts to be broadly accepted, which is great. So getting more of that information out there, we think, is a helpful, positive thing. So I think the cover sheet for the framework, or the framework PDF itself, is probably in 8 languages, or roughly around that, and the entire ebook in English, Japanese and simple Chinese. And then nearly done in Spanish and Italian, and a couple more in the possible pipeline.
Great. So thank you for joining us. Hit the feedback button on the website so that Tim can take your feedback.
If I don't get back to you, Darren will shortly.
I definitely will. I definitely will. I check your email all the time, Tim, when you don't know.
Yeah.
Good. All right. Thank you, and we'll see you next time.